Hi folks, it is a concerned Dr. Miskoff. It's about 9 p.m. April 4th, 2020, another long day fighting COVID-19. And tonight I was going to take on the topic of insomnia. And I'm getting a lot of text messages and emails, complaints about not being able to sleep. And of course, no bigger stressor in the world currently than coronavirus. Fact of the night, about 20% of the U.S. population takes either an over-the-counter or prescription medication for insomnia in the United States each month. So about 1/5 of the population is on some sort of medicine on a monthly basis if you look at it for insomnia. And we know there's acute insomnia, there's chronic insomnia. Most chronic insomniacs we consider several months out of the year for at least 3 months. But the acute insomnia, much of what we're seeing right now, is likely related to COVID-19 or a side effect of COVID-19, loss of job, loss of loved one, grieving, of course, just anxiety and stress of what's going to be. I think there's so many patients that suffer insomnia on a chronic basis as well, and hopefully these patients will not convert from the acute phase to the chronic, which happens in about 1/4 of the population. So when you're assessing somebody with insomnia, you want to look at their social background, their medical background, of course, their psychiatric history. Up to 1/2 of these patients may have some sort of mood disorder or psych history, bipolar disease or schizophrenia. They may have chronic pain syndrome or even acute pain, nocturia, so waking up in the night frequently to go to the restroom, whether it be because of a enlarged prostate, whether it be because they had a sleep apnea history or obstructive sleep apnea, and they're waking up because of the apnea, and now they're awake and they feel okay. Now I have to use the restroom. Dyspnea, the COPD population we'll brush on briefly. Restless leg syndrome, another huge cause of insomnia, especially the sleep onset type, where they have that creepy crawly feeling upon going to sleep. And post-traumatic stress disorder, and of course medications. Probably the most common medications for causing insomnia or exacerbating it would be the stimulant therapies, whether it be taking a stimulant to stay awake you take it during the morning, a Ritalin type thing, or a methamphetamine, Provigil, modafinil type products. Remembering that the half-life of some of these drugs is greater than 10 hours, and therefore if it's taken a little bit later in the morning, it could roll over into the evening time, so be aware of that. You can reduce the doses, you can use shorter acting agents. Those are management strategies if you are in fact on stimulants. Some of the antidepressants, up to 20% of patients that start antidepressants, whether it be the serotonin reuptake inhibitors or the serotonin norepi reuptake inhibitors, can have this sort of insomnia, prescription-induced or treatment-induced insomnia. Again, you can adjust the dose. You can take it more in the morning. That may help. Patients on chronic steroids, and steroids have gotten attention during the COVID-19 pandemic and whether or not to use them. I'm now seeing some team members using sort of salvage or higher dose steroids, patients in worsening respiratory failure and ARDS, and exactly how to do that is debatable, and there's no clinical trials to support that at this point. There are some countries looking at it in clinicaltrials.gov, as I alluded to yesterday's vlog. Opiates, of course, we try and discourage them. They can cause, even though you would think they would help you fall asleep, they can cause sleep fragmentation and nocturnal or nighttime awakenings. They can cause central apneas and often require treatment concomitantly with a BiPAP or CPAP type of unit. They can worsen the apnea. Sometimes they need a special type of device with a special algorithm for central and both obstructive apneas. So that's something worth noting. Most importantly is how they handle their sleep hygiene, and sleep hygiene doesn't mean taking a shower before bed, but rather keeping the same bedtime and rise time, and we'll go through some of that. Poor sleep habits, this type of thing, and often using sleep diaries, and you can print those online. I believe the American Academy of Sleep Medicine has these sleep diaries you can print out to kind of keep track of your bedtimes and rise times, and can be helpful to both the patient and the clinician. Looking at how sleepy they really are and quantifying that with a scale called the Epworth Sleepiness Scale, and there's other scales out there as well. being able to assess the anxiety associated with not being able to fall asleep, and some of these patients will form rituals. They'll clock watch. We advise them to either get rid of the clock or turn it around, and set alarms for certain times very loudly so that you can have to get up and actually go to the clock before just hitting the snooze bar. Also look at whether or not there's children in the bedroom or in the bed, in fact, or pets in the bed. Of course, it's not advised to have either. A bed partner, do they have sleep apnea? Are they snoring? Are they affecting your sleep? Are electronics being used in bed late into the night? And is that becoming a routine? Patients often overestimate their total sleep time, or underestimate their total sleep time, I should say. They often have misperceptions about the insomnia itself, so really getting a good history can be helpful in breaking that down and then offering some sort of treatment. In the acute short term, less than a month type of insomnia, again, looking at those stressors, addressing those stressors. It's pretty obvious today why people are having increase in insomnia, at least the short-acting type. It is reasonable to give them pharmacology for 2 to 4 weeks and possibly reducing dose on a weekly basis to get them off quickly, so they're not converted to a chronic type of maintenance medication, if you will, and always being aware that a lot of these medications have hangover effects. Sometimes they're just not covered under insurance policies, and that brings us to cognitive behavioral techniques, which is the non-pharmacologic approach. And when studied, in insomnia, you really find that it's as effective as pharmacology. When looking at CBT or cognitive behavioral techniques plus pharmacology, it certainly beats out pharmacology alone. But these are techniques that can help you relax and going through certain things about the sleep history. We prefer that the adult patient at least gets 7 to 8 hours of sleep a night. That would be in the ideal world. A sleep latency of less than 20 minutes, and when the lights are out, we want that patient to be asleep. Up to 30 minutes is probably acceptable. When you get over that, we start to call it insomnia. Again, the goal here is to get the patient in the bed and have them sleep as much as possible while they're in the bed occupying it, or have what we call a high sleep efficiency. So the total sleep time should be close to, hopefully, the amount of time you're actually spending in the bed. Again, when you're looking at CBT or cognitive behavioral techniques, insurance doesn't always cover it. Docs that do sleep medicine are also involved in pulmonary and critical care may not have the time or even the training to provide the best CBT. I had mentioned on one of my earlier vlogs about using Sleep Sounds, which is a free app you can download on either, I believe, Apple or Droid, Microsoft platforms, and you can add certain sounds to the background, and it's kind of cool and it's free and it may help you relax. But really addressing the common behaviors and thoughts that the patient's having, whether you do CBT as a one-on-one, now's a perfect time to do it as telemedicine with COVID-19, and really it is possible. Some integrate biofeedback or neurofeedback type of sessions. Usually they're 4 to 8 sessions. They can also be done in a group setting and online. Keeping the same exact bedtime and rise time. Again, keeping the amount of time in bed hopefully close to the total sleep time. Using the bed for sleep, and pretty much one other thing, and we know what that is. Sleep when you're sleepy and not just sleeping because you have nothing else to do or you feel depressed. Other things such as stimulus control or muscle relaxation, of course yoga, and avoiding naps is advised. You don't want to be taking naps during the day if you don't have to, because then you're not going to have that propensity to want to go to sleep, and trying to be as comfortable as possible. Obviously addressing the anxiety component and thinking about those catastrophic thoughts associated with sleepiness and trying to disassociate that. Inappropriate expectations about hours of sleep to the patient and discussing that, and meditation, and mindfulness, relaxation, and again, stimulus control. When you look at cognitive behavioral techniques, and if they're done right, you can actually get the sleep latency improved by about 19 minutes or have them fall asleep almost 20 minutes sooner. And the amount of time awake, will be about 26 minutes less. However, when you really look at the total sleep time, it's only about an 8-minute differential if you use CBT, and the effect is for about 6 to 12 months. Looking at pharmacology, there's many different neurobiosystems involved in neurotransmitters. We all know about Ambien. Most of us have heard of the non-benzodiazepine receptor agonist, but using the benzo receptor, obviously benzodiazepines such as Ativan and Valium, Xanax, these are all Klonopin, these are all well known, but can suppress respirations, and we prefer not to use them. Some say burn brain cells, increase risk of potentially dementia. These are all questions that exist. So we try to avoid the benzodiazepine class. Next in line would be the zolpidems or the Ambien, which is a very similar type of mechanism. Maybe GABA involved in some of these. There's also sedating antidepressants. We'll talk a little bit about that. Melatonin I covered in a session that got a lot of views. There's melatonin groups online, and really a very safe product at micro doses, needing about 0.3 to 1, maybe up to 3 milligrams, and maybe inhibiting NF-kappa beta, as we mentioned, which could be involved in the ARDS pathway. Not all hospitals have huge supplies of this, even though it's inexpensive. It could have a dual purpose, potentially for helping sleep and potentially with inflammation. Rezeram would be the prescription version, where it's hitting the different melatonin receptors, receptor 1 or A and receptor 2 or B. So this will be an agonist to those receptors rather than being the pure melatonin product itself. Whether it has anti-inflammatory effects like it's been studied in melatonin is I'm not sure on, and is debatable. The orexin receptor antagonist, so orexin is the protein also known as hypocretin, and this is the protein involved in narcolepsy. Patients are deficient in this protein typically. You can do spinal taps to measure it at research centers like Stanford, where they have a huge sleep center, very well known. In other places like Mayo and other places, big centers may do that. But this is a play off of sort of the narcoleptic who's has a reduction in those proteins, so this antagonizes it, therefore sort of creating, if you will, the narcoleptic or a sleepy environment. So Belsomra is one of those, again, orexin receptor antagonist, and then there's a dual antagonist named Dayvigo, or Dayvigo, lemborexant, which is a newer product, but may have extra mechanisms on that receptor. And again, we mentioned the Ambiens. Those are the non-benzodiazepine, sort of benzodiazepine receptor agonists. Ambien or zolpidem, Lunesta, Sonata, very well-known products, and a lot of studies around those. The antipsychotics can be used as well. They tend to have sleepy effects. When you look at comorbid conditions and those with schizophrenia or psych disorders, mood, anxiety, often Lunesta has been studied and used in that, and up to 50% of patients may have a psych disorder with insomnia. And psych disorders can be very, obviously a broad range of disorders from mood and anxiety all the way to schizophrenia and other more rare disorders. Remeron or mirtazapine has been used as well in psych disorders with some effect. And remember, it can cause dry mouth, and these can also cause hangover effects or sleepiness the next day. So using lower doses, or at least weaning these, may not be a bad idea. Obviously, you want to treat the underlying mood disorder, and if you just treat the disorder, that may help the insomnia, so you can get to it that way. Post-traumatic stress disorder and nightmares, I think there'll be clinicians that we find down the road that have a form of PTSD from being involved in the pandemic and treating, and loss of lives and all the anxiety involved in potentially catching COVID-19. I think this will be looked at if it's not already. But nightmares and hypervigilance, if you will. I know we've used an old alpha antagonist, prazosin, which was used for blood pressure and prostate enlargement. I've seen that used in VA studies and those with nightmares, and I've had some success with a few patients, at least veterans with PTSD and nightmares. But trazodone is also considered one of the standards for nightmares and PTSD and insomnia. Substance abuse, obviously, good time to stop that if you can. Obviously, it can affect sleep as well, whether it be alcohol that helps you get to sleep initially, but then converts to aldehydes and stuff like that in the second half of the night, can affect you. And of course, we talked about opiates and benzo addictions as well. Sometimes using medications that help sedate you but don't have as much of an addictive property, such as Neurontin or gabapentin, trazodone we mentioned, and Seroquel can be helpful. How about those with Alzheimer's? Trazodone has had some benefit, at least short-term, for moderate to severe, about a 2-week benefit there. Some with Parkinson's disease, carbidopa, levodopa, sort of gold standards, and there are other medications for that, but Lunesta has been looked at there with some benefit, and here comes melatonin again in that class. And again, with obstructive sleep apnea or patients who close off their airway during sleep, Lunesta would not be as sedating, and using more sedating or respiratory relaxing medications, if you will, could be dangerous. You want to couple that with their CPAP or BiPAP. Sometimes we use stimulants on the daytime side of that, such as Provigil or Modafinil or Nuvigil, and of course the newer one, Sunosi, which could be used as a wake-promoting agent for obstructive sleep apnea. Got a dual approval for narcolepsy and sleep apnea. And we mentioned restless leg syndrome. Sometimes this overlaps with pregnancy. Can't imagine being pregnant at this point in time and going through COVID. It must be very difficult. And restless legs can be another complication of pregnancy. And you can see low iron levels and ferritin levels rather. So iron supplementation can be helpful. But with restless legs, we typically use dopamine type of medications, or Neurontin, gabapentin, and Lyrica has been used as well. And the same with pain and insomnia. Using Neurontin or Lyrica can be helpful without such sedating and hangover effects. How about my COPD population? Up to over 25% of emphysema and chronic bronchitis patients can have insomnia. You need to be careful with respiratory suppression. Another instance where we've learned how to use melatonin in that group. There has been some studies with that, and it's helped. Neurontin, again, and sedating antidepressants can be helpful. Tempting to want to give the Xanax, but again, it has to come with warnings and risk, and we prefer to use medications that are less sedating if we can get the benefit. And chronic kidney disease, worth mentioning, meds listed for those of use could be Zolpidem or Sonata, clonazepam, again with caution. They have been shown in studies to improve sleep quality. Melatonin's been looked at. It's helped in the short term, but didn't hold up at a 1-year trial. We mentioned pregnancy also with the restless legs and replacing the iron. But let's not forget about over-the-counter meds may be the safest approach in pregnancy. Even though Benadryl can make you feel kind of lousy the next day, it at least is considered one of the safer agents, if you will, in pregnancy. Doxalamine or over-the-counter preps as well. And menopause, of course, let's not forget that. Whether it be hormone replacement therapy, and these all come with risks. Effexor, Neurontin, Lunesta, Lexapro, some of the more common sleep aids that have been used in menopause. And again, hormone replacement therapy should be discussed. And all these medications should be discussed as a disclaimer with their healthcare provider, the risks, the benefits, of course. And if you don't want to use medications, then good old yoga should do. So with that, I want everybody to have a great night. Please try and relax. We are all in this together. And I'd like to also give some thanks to my brother, the company my brother works for, Palo Alto Networks, for supplying dinner tonight to the medical intensive care unit. That was very nice. They made 60 box dinners for the ICU. Hopefully that got delivered safely. And again, just a thank you to our nursing staff throughout the hospital and respiratory therapy. We've already thanked the docs, but the ones that are really in those rooms consistently getting the heaviest exposure definitely deserve some extra words and kudos. The docs are working hard, but you guys are really the true front line that are in there constantly. So God bless you all, and please stay safe. Thank you.